I got it. Good afternoon, everyone, and welcome to Greater Atlanta APIC's November chapter meeting. It's good to see your faces. So today we have a really good presentation in store for you. But first, we're going to kick it off with some announcements. First, you're going to hear about it again at the holiday luncheon, but I just want to give a shout out to Mr. Caleb Price and Ms. Pam Falk, who have served on the APIC board tirelessly for the past few years. They will be transitioning to other things. And so Pam serves as our education committee chair, and Caleb is our membership committee chair. So you get all the emails from Caleb. So I just wanted to give him a shout out before we move forward with the program. Those areas will be open. So be on the lookout for just more details about what those committees and the duties entail. And again, thank you for serving. Secondly, if you have not registered for the holiday luncheon, please do so. It takes place on December the 9th. It will be at the zoo. The first 60 registrants get a free ticket for admission to the zoo that day. The cost is $20 for members and $25 for non-members. So we'll send out the holiday luncheon bulletin again, so you and your team can get registered. It will be a good time. We'll have Dr. Alex Kalin, from the CDC, who will be presenting. It'll be a good time for us to get back in person and some good fellowship. So please remember to sign up for that. Next, I'm going to turn it over. I don't know if Karen is on from DPH, but I know that she had a few announcements that she wanted to give, a few updates she wanted to give about the goings on.
Hi, I'm here.
Department of Health. Awesome. So I'll turn it over to you, Ms. Karen.
Good afternoon, everyone. So nice to see everyone's faces and names. So I'm just going to give a couple of updates from Georgia Department of Public Health that we've been seeing. So for the month of October, we had about 9 non-COVID outbreaks that were reported in healthcare facilities. All of the 9 were reported from long-term care facilities, either skilled nursing or assisted living. 7 of the 9 were influenza, and 1 was norovirus, and 1 was RSV. We know we are seeing a lot of RSV in our kids lately. Along the lines of influenza-like illness, intensity indicated for Georgia during week 44 was very high. We are at the top of the food chain right now, and along with several other states with high flu. And you may be seeing that actually number 13 on a scale from 1 to 13. So we're like in the stratosphere. Since the start of the new season, we've had 655 influenza hospitalizations in the metro area of Atlanta, 171 reported influenza outbreaks, and 2 confirmed influenza-associated deaths. One thing that Jeannie wanted me to let you guys know is that the CDC will be releasing a COVID-19 report regarding COVID-19 mortality in the United States. And that report will be available, and we'll probably get the link out to you at some time. Some of the key findings are deaths there. Deaths from COVID-19 have decreased. However, there are thousands of COVID-19 related deaths that are still reported in the United States weekly. Also, COVID-19 related in-hospital deaths are rare among young adults. Those that do occur are most often among patients who are not vaccinated. So please continue to push that. And then let's talk a little bit about Candida auris. And so from the state level, as of October 27th, Georgia has identified 50 cases of Candida auris. 18 were from clinical patient specimens, and 32 of those were from screening specimens collected during investigation by Georgia Department of Public Health. You know, we have an IP team now that's doing a lot of MDRO work, and so we've started to screen more than we have before. So you'll see here that we have found more from screening. In the Atlanta metro area in recent months, we've identified 8 Candida auris cases, 3 of those were from clinical specimens and 5 from screening. So some recommendations from the Department of Public Health that we are hoping that you take back to your facilities is, 1, make sure that your lab has an algorithm for detecting CRs. The other is consider screening patients. That could be patients who have had an overnight stay in the United States in the past 12 months, particularly if they have a carbapenemase producing organism such as an NDM-CRE, or their overnight hospitalization within a country with documented cases of CRS. Also consider screening patients who have received care in LTACs or VSNFs, since they seem to be at high risk historically for colonization. Patients who spent overlapping time on a unit with a known CRS patient as well. Reviewing your infection control measures around this, ensure that your ICUs have disinfectants that are effective against CRS. CRS patients will need to be on isolation when they come back to your facility. And like I said, DPH has been investigating all CRS cases, and we're making CRS reportable, so that should be coming soon. And there is a case report form in SENS that you can complete. So that pretty much covers my update from the Georgia Department of Public Health. Thank you, Andrea.
Thank you, Ms. Karen. Thank you so much for that update. So now, without further ado, I'll turn it over to our president-elect, Mary, to introduce our speaker for today.
All right, so I'm going to introduce our speaker. So today we have Fiona Nemetz. She is the System Director of Environmental Services, Safety and Security for Northside Hospital. Northside is a 5-hospital system with over 1,600 licensed beds. Fiona's prior roles include leadership positions at St. Joseph's Hospital and Hyatt Hotels with responsibility for environmental services and other support departments. Fiona shares a passion for EVS leadership with over 30 years experience in both the hospitality and healthcare industries. She served on the National ASHES AHE board from 2008 to 2010 and was president in 2010. She has published several articles that highlight the importance of an engaged EVS team in partnership with infection prevention to produce a quality patient experience. Most recently, Fiona has focused on the partnership between EVS, nursing, and infection prevention to drive outcomes and quality, HCHPS, and patient outcomes. She has led the EVS team at the Atlanta campus to achieve the 2015 AHE Department of the Year Award for EVS, and in 2019, the Cherokee campus was also awarded this prestigious recognition. In 2016, she was awarded the prestigious Phoenix Award by AHE in recognition of her professional accomplishments and contributions to the EVS profession. In 2017-18, Fiona presented to audiences both internationally and within the United States, including APIC chapters in Kentucky and Georgia. Additionally, she became a master trainer for CHESP and CSCT, which are EVS certifications for training of frontline staff provided by AHE. Fiona holds a bachelor's degree in hospitality management and a master's degree in healthcare administration. So with that, Fiona, I will turn it over to you, and you have control of your slides, so you can go ahead and get started.
Well, thank you, Mary. First and foremost, all that information that Mary presented could never have prepared me for what we've been through the last couple years with COVID. To say the least, it's been a journey, and I will share with you, I couldn't possibly have done it without the partnership from the infection prevention team at our health system. They provided amazing support, and I mean, we had questions coming up every single day, and they were there for my teams that were scared and challenged by everything that the pandemic presented for us. So without that, I'm going to go ahead and talk about the objectives of today. Identify service levels that may have changed during the COVID pandemic and compare with pre-pandemic levels. We will get into that in a minute, but it's important that we don't assume that everything that environmental services offered before the pandemic, that we are able to continue those service levels. Assessing collaborative solutions that can be developed between infection prevention, environmental services, and clinical leadership. We've always got to be moving forward, looking at alternative ways to solve our problems. We can't just walk away from them, because otherwise, of course, that would impact our patient care, and ultimately that's what we're here for, the patients. And then demonstrate implementation techniques through partnership with infection prevention, environmental services, and clinical leadership. Throughout my presentation today, you will hear I cannot do my job and my team cannot do their job without the support and the information that infection prevention provides us. They have just been phenomenal. Okay, let me give you a little bit of a summary of what is going on in environmental services across the nation. I was at the annual conference in Orlando for AHE, which is the Association for the Healthcare Environment, at the end of September. And pretty much what I'm presenting here, everybody's experiencing. So it's not just here in Georgia. So as most of you are aware, as the pandemic got started, everybody moved to a virtual interviewing process. And here we are, I'm presenting virtually today. Well, one of the challenges we found in environmental services, that did not work well, because a lot of the staff members didn't even have a device other than their phone to conduct those interviews on. And so that was a super challenge. So we were one of the first departments that our health system that went back to face-to-face interviews. Another thing that has really come into play is the competitive pay in other industries. As you're all aware, clinical staff are doing this, but it's also very apparent in the environmental services world that pay has increased, and we as a health system had to bump our minimum pay couple months into COVID. It wasn't long into COVID that we bumped everything to a minimum of $15, and then we compensate for experience as well. But we just wasn't cutting it where we were before. This is an interesting one. Healthcare has a stigma that candidates will have to work around patients with contagious conditions. That is becoming more and more apparent with our applicant pool, and even to the tune that we'll have some individuals that go through our whole application process, our onboarding, and they, then they come in and they say, well, I want to work in an environment where there's no opportunity for me to get sick. And we, of course, flip that script on them and tell them that they've got to have the personal protective equipment, and they will be in that environment every day. But it continues to rear its ugly head for our teams in that, people ghost us after 2 or 3 weeks. And if we finally are able to get them on their phone, no, I just don't want to work in that environment where I might be exposed to things. So it's a big challenge for us. And, they don't have the education level that all of you have. They don't have the education level that the nurses have to understand that if they're wearing that personal protective equipment, they will be protected. The Great Resignation that occurred during COVID has changed our workforce, and I think everybody knows it. People don't want to come to a location every day. A lot of them want to work from home, and we just have no way to offer that in healthcare. It's kind of interesting how the world is changing around us and how we're going to apply all this to healthcare. I have 2 sons, and I kind of tried to wrap my head around some things they told me over the weekend. Son number 1, this coming Friday, is they have Take Your Pet to Work Day. And so he signed up, and he's going to be taking, the golden doodle to work. And I was like, okay, can't really offer that healthcare environment. Son number 2 went on a retreat with his company last week in Salt Lake City and spent 3 days outside Salt Lake City, where they had a personal chef come in, serve them healthy food. And they just went through a whole retreat, cleansing of the mind and getting their mind set for their next big project. They both work in the nuclear industry, but it's kind of interesting. It just shows you how the world is changing around us. And it's challenging in healthcare because we can't offer all those things. We cannot offer the work from home, to our environmental services staff or our environmental services managers, because we need them here every day. And then finally, the work itself is very physical, and workers are becoming more and more discerning when we're even in the interviewing process. Well, I don't really think I want to do something that requires that much hard work. So it's definitely becoming more and more challenging, but we have to keep our foot on the accelerator. It is our responsibility as leaders in environmental services, with the support from our infection prevention team, to keep this program moving, because we all know if we don't keep our healthcare environments clean, then they're not safe, and ultimately the patients aren't safe. Some of the opportunities that we've targeted is, our applicant pool has shriveled up. Human resources is not getting the same number of applicants for our jobs that they did pre-pandemic. So we saw this pretty quickly during COVID. So then I said, let's have a job fair. And then of course the first thing was, well, we can't have a job fair because we can't have all those people in the same room in COVID. So then I suggested, well, why don't we go down to our parking deck at one of our MOBs? And there was kind of a silence from the HR department. They came back to me and they said, let's try it. And our first targeted job fair down in our Midtown location, we got in 203 applicants. And prior to that, we had not seen 203 applicants over a 120-day period. So we realized we needed to do those job fairs. And now we go out and target them around the locations where we want to hire the people. And it really has been a great solution for us. I mentioned already we had to increase the minimum pay. The health system as a whole has done a phenomenal job giving high referral bonuses to both the applicant and the referral source, and that has brought in a lot for environmental services. Now, this is one I never dreamt we would be doing, but creative flexible scheduling for our applicants. So if they come to us and they say, I can't get to work until such and such a time, we are building schedules around their availability to a certain point, because we realize that we've got to be more adaptable in this environment. We, back before the pandemic, had built an environmental services levels program that runs throughout our health system. And basically we have 3 levels in that, and we leverage the Association for the Healthcare Environment Certification Program that bounces them to level 2, and they get additional pay with that. But we're looking at adding an additional level so that we can continue that career ladder, and they have, they have a place to go. And it looks like a career opportunity joining our environmental services team. Blue Vase Award. This has been a huge success program. We actually went out and bought some blue vases, and at each of our locations, we recognize the department that has the highest HCAP scores for environmental services, and it's a joint award. It actually, the blue vase resides on the unit, on the somewhere around the nurse's station. And we do a celebration. We bring along food, cookies, cupcakes, and we have a little recognition ceremony for the unit that is performing the best. And it's really helped us bring back a focus on what's important, which is, of course, patient satisfaction and making sure we keep the place as clean as possible. We're really upped our game on our staff recognition. That's been super important. Because we want to make sure we hold on to the good ones, or at least as many as we can. But I'll be very transparent with you. Our turnover has changed and it has increased. It's starting to stabilize right now, but it's still not back to pre-pandemic levels. And then finally, in one of our markets where one of our hospitals is, we just cannot, we can't move the needle. We're struggling to move the needle on the number of vacancies. So we have purchased an autonomous floor scrubber. And I will go into that in a little bit more detail in a minute. I actually have a slide on it. See, there we go. So we do have a dedicated trainer at Northside for all of our environmental services staff. They get brought into a classroom environment on the first day, and we go through everything from the nuts and bolts on our chemicals to PPE. We actually have them don and doff the PPE, which became very helpful as the pandemic hit us. But and it is challenging for us in getting them all to come to one location, but it's really worthwhile because we make sure that they at least all get a consistent first day message with everything administrative that they need to know, when we're not putting anybody out there who doesn't know the ins and outs of our chemicals, where to locate the SDSs, and also the different isolation statuses. You know, a lot of our employees are coming from other industries and they've never dealt with isolation statuses and donning and doffing of PPE. The other thing, as I've said, we're doing the solutions on the bottom of this slide, the job fairs, the recognition, and then we do 30 and 90-day rounding on each new hire, just making sure that they've absorbed what we have taught them. And then it's usually at that point that we actually get them into a small room and start our role plays. The importance of what they are messaging when they are cleaning in front of patients, not just patients, but in our sterile environments, of which we have quite a few of those. This picture in the next slide shows one of our graduating classes. This was a level 2 class that we had in May of 22. We typically have 2 level 2 classes a year, and we take them into a classroom setting for 3 days, and we teach them everything that is in the CHESP program that AHE has put together, and then they take a national certified exam, which is daunting for some of them, you know, because they may not have been in the that type of environment, but they do a really good job, and for the most part, they do pass. We cannot help them through the testing. You know, it's done through a testing center, and occasionally we'll have, you know, somebody who doesn't pass it, but then we do the re-education program and we get them through it. Along those lines, we're also spending time developing our managers. They're living in a different world and the challenges associated with it. So we have them in quite a few training programs, both through we actually use Aramark as our vendor for our environmental services management, and they have a lot of product offerings, but then we also put them through our health system offerings, which are excellent, through our learning and organizational development program. Departmental meetings, those were a huge challenge during COVID, but we've of course stepped those back up. And one of the big wins is when we have infection prevention come to our departmental meetings and spend some time messaging to our team. It could be anything from you know, the hand hygiene presentations that you all do an outstanding job of, to sharing with us, you know, anything when we had the new isolation signs that came out for COVID. They just really appreciate when infection prevention comes to our meetings. So make sure you connect with your EVS directors and managers and see if you can be a part of their departmental meetings. We have a monthly newsletter that we put out, and we've really expanded that. Since COVID, we've been forced to. So when COVID first came into place, and you all remember this because you all were the messengers to us, how much changed so rapidly, and we had to get the information out pretty quickly to the staff. So at that point, we were doing almost daily newsletters, printing the information off, and then our managers were delivering it to the staff and going over it with them individually, because you remember we couldn't have the departmental meetings. We do patient experience fireside chats. That's where our managers are up on the floors and they actually interview the patients to find out, are the environmental services teams doing what we think they're doing when they come into the room. And this is really valuable information because if they're not, it gives us an opportunity to get it corrected. And then we have our employee resource groups, Empower, Impacto, and Lead. Just more additional resources that we use to keep our both our employees and our managers educated. The name of our levels program is the STEP program, Service Technical Excellence Program. And as I said, we built it upon the AHE certification program. And currently right now we have 176 level 2s and we have 18 level 3s, but we're about to graduate another group of level 3s, which will double that number. 69% of our staff across the health system are either certified in CHEST or CSCT. The difference between those programs is one is more general environmental services, whereas the CSCT is in the surgical environments. Okay, let's continue. Okay, here's an opportunity where we demonstrate this blue vase. These were the vases that took us a minute to source where we were going to find blue vases. And then you can see here, this particular celebration was they had the 97th percentile HCAHPS on this unit. And there they are celebrating with the leaders and the nurses on the unit. The importance of recognizing our team members, the fact that when they do go the extra mile and they get a shout out from our patients. Really, really important for the self-esteem of the environmental services staff, because from time to time, they have the perception that they are the lowest members on the ladder. And we spend time, and I know our infection prevention team supports us on this, making them feel special and making them realize what a difference they do make in patients' lives. And they're not the bottom of the ladder. Without them, we couldn't make the hospital run. And it's really important. When I first came to work here, they had some uniforms that didn't do a whole lot for them. And we immediately moved them into scrubs similar to what the clinical staff wear. What an amazing difference it made for our staff once they were, recognized and included as part of the team in our particular clinical units, and also even when they're cleaning in our sterile environments. This is an example of our newsletter. We go through making sure we recognize the superstars. This one was actually back a little way when we were doing the virtual interviews, and that was us in a room doing the virtual interviews, and we realized real quick that that didn't do too much for us. So we definitely got that. Here is a slide with the autonomous floor cleaning machine, the Nilfis Liberty. We have just purchased one of these for our Northside Forsyth location. And robotic technologies and environmental services have been around for a long time, but the new ones are pretty nifty. You may or may not have been in a Walmart or Sam's or a Costco where they've got these machines running, but in the past, they haven't done that great in healthcare because their recognition of running into something or someone was somewhat challenging. But they've come a long way. I will tell you that they're not cheap, but when you can't get FTEs to fill your roles, it's worth the opportunity. Interestingly enough, this one also has a UV built into it. So not sure the advantage of the UV on the floors, not sure if it's going to change our floors, but this one does have UV built into it. And, my experience from environmental services is a floor is only as clean till the next person walks over it. And of course, we'll be using this in our public space. So that will, that gets a lot of traffic. But one of the things when you're looking at these pieces of equipment for anywhere, it's important that you have a lot of open space and long hallways. Like we looked at them for our main hospital, but it wasn't a good solution because we have a lot of chopped up hallways here, and it wouldn't be able to get the autonomous runtime to really provide us with the advantage. So I'll keep you posted, see if it helps to be a solution for us in environmental services. Another thing that constantly needs to be visited between environmental services, the clinical departments, and infection prevention is our responsibility matrix, which takes into account each item in a particular environment that you've selected. This one happens to be surgery. How's it supposed to be cleaned? What's the IFUs on it? What's the product that needs to be used? And who's accountable for that? And I know that Joint Commission and DMV are starting to look at this with a more critical eye. Especially, it's no longer acceptable to say that, well, you know, if the manufacturer says you've got to clean it with one of 3 products and you have a similar product, you have to have done the risk assessment on that similar product and get approval from the manufacturer. We're dealing with an issue in the health system right now where we've got chipping of paint on a certain item within the surgery environments, and working collaboratively with the manufacturer and the leadership in the surgery departments. As you can probably guess, the manufacturer is not jumping on up and down saying, oh, it's our problem, we're going to fix it. And really the only solution for this particular item that we're looking at is that it's going to have to be replaced with non-defective. And they are pointing the finger, claiming that it's the cleaning products that have disintegrated the surface. But if you take this particular product and you look out there on the internet, there have been numerous cases reported of the paint chipping on this particular item. So more to come on that, but it's important for the collaboration, everybody working together in the health system and as a team, a supportive team. I'm sure you all are familiar with Teresa Jarmick, our system infection prevention. She runs all of us together as one team, and she's very approachable, and that's so helpful for us in environmental services because we come up with items all the time. And the other thing is post-COVID, the whole supply chain and the services that we can provide, it's completely changed. I'm going to go into that on my next slide. So one of the things that we had to deal with through COVID was our product manufacturer for our soap and hand hygiene products couldn't provide us with product. And I know everybody had a challenge with hand hygiene products, but there were certain environments where the supplementary ones just didn't work. You couldn't just put a little hand pump dispenser on the wall in surgery. You know, it was going to fall off. So we had to make a wholesale change for the entire health system. And you want to talk about a partnership needed between infection prevention and everybody to make that change. One of our newest supply chain challenges is shower curtains. All of a sudden, all of our sources, and I mean, this is fresh off the press within the last couple weeks, we are unable to purchase from 3 manufacturers that we've been purchasing our shower curtains for our patient rooms. And we're working through those challenges right now. I'll be very honest, we've been purchasing them from retail places until we can get a handle on what the long-term solution is. But materials management has also had to partner in that one for us. Here's a big topic that I could do a whole presentation on its own, is cubicle curtains. I think a lot of us across our facilities have changed to snap-on panels, which does make the cubicle curtains easier to change in the patient rooms. I remember when COVID first came along, and our policy as a health system is that we will change the cubicle curtains upon discharge of every isolation patient. Well, you can imagine, first month or so into that, we knew we couldn't sustain. So then we realized that we were going to have nobody walking through the facilities, so we could take those down in the rooms. We didn't need the privacy curtains, so we took them down. But now our big challenge, as we have ramped back up on the cubicle curtains, is there's a couple issues. The manufacturers of these cubicle curtains have got supply chain issues. They, whether it's they can't get the fabrics they used to have, or they don't have the manpower at their manufacturing facilities. It's a whole combination or a whole host of events. And then the other piece is the contract cleaning companies that we use can no longer provide the service levels that they used to be able to provide. So it's requiring us to escalate our inventories and increase the number that we keep on hand because the companies cannot provide. In the outpatient setting, we have a company that used to come in at our surgery centers, primarily take all the cubicle curtains down on a Friday night, clean them over the weekend, and then they would come back and put them up Sunday night so that they were ready for business on Monday morning. They can't offer that anymore. They said they can't find people that will work the weekends and are willing to do that. So again, we've had to come up with a workaround, but you might just want to check into how's that working, not just in your inpatient, but your outpatient settings, and how infection prevention can support. One of the things that we did find as we did our analysis were that we were exceeding our policy of the frequency, and we decided that it was better to get it done and make sure that we at least met our policy. And so that's what we have moved to make sure that we've met our organization's policy on cubicle curtains. The other thing to consider on cubicle curtains is there are disposable cubicle curtains out there, but just making sure that if you do decide to use disposable, that you are following the manufacturer's guidelines on how often the frequency they should be changed. And also not just that, making sure that they are marked on them when they were hung, so you know when that frequency occurs. We use them in a couple of our environments on a regular basis, but then we have added those in places since the pandemic, just because we've got such a problem with the processing of regular cubicle curtains and getting our inventories to where we need them. Eventually, we plan to eliminate them, or not eliminate. We're going to leave them in certain environments, but we won't be using them in as many environments once we get our inventories back to where they need to be. IFUs, I mentioned it before, the accreditation organizations are just laser focused with this. And it's important that everybody's following the instructions for use. And I don't know where it's going to land. I know that Infection Prevention and I are partnering with, the surgery and cath lab and those departments, but it's unrealistic to think that we all are going to have 130 or 140 different chemicals so that we can meet all the IFUs for the item manufacturers. So we're working closely on that, and we don't have all the answers. It's just something to make sure that you are looking into at your organization and supporting environmental services and vice versa on what the product offerings are and the compatibility with the equipment. Okay, Pandora's box, the outpatient settings. Of course, this is outpatient surgery, but it usually extends beyond just surgery. But for the most part, I think you will find that your organization has contract cleaning in those environments. And what's interesting is we don't always have the control over the contract cleaning in those environments. So typically in our surgical environments, we do, because we make sure we write that contract. But when it comes to other settings, infusion centers, there's often part of the building offerings, and we're only leasing space. So then we have to orchestrate those conversations with the property management or the ownership of the building, trying to manage the contract cleaning up to our performance levels. One of the things that has been the best solution for that is having comprehensive contracts if we contract. But once again, I said we don't get to contract with everybody, but then the monthly walkthroughs with contractors, infection prevention, and the clinical leaders of the department. That's how we've done the best job of establishing the accountability. But it's very, very necessary. Making sure that the if it's terminal cleaning for sterile areas, that the contractor is completing the terminal logs. That can be an opportunity area. In also making sure that if we're doing any validation cleaning, you know, CDC recommends you do some type of validation process. It doesn't specify which one. You can use the DAZO, you can use the ATP. They actually talk about physical inspections. So, you know, these monthly walkthroughs with a validation, you know, visual as well as one of the technologies is an excellent way to go. And then one of the things that I've been successful in leveraging here at Northside is, at least in our sterile areas, that we require, if we issue a contract to a contractor, that they participate in AHE's signature training. We will allow them to come and attend our classes when we run the surgery cleaning class, and we've even done a special class for them. But just making sure they've got some skin in the game and some ownership in what they're doing, because too often they get a contract for a surgery center and then they'll hire Sally, and Sally's not given a whole lot of direction in making sure that that environment is clean to our standards. And of course, those are basically the AORN standards for the most part. Okay, well, that's pretty much my summary of what's changed since COVID for all of us in environmental services. Does anyone have any questions? I guess we would put the questions in the chat box.
So Fiona, hi, this is Pam.
Hey,
I'm here to facilitate the questions. So
okay.
Excellent presentation. Thank you very much. I just know that how important it is to have communication between, you know, infection prevention and EVS. You can't do it without each other. It's really a big deal. So open it up to questions, but while everybody's thinking about it, and then you guys, you can just unmute yourself, and you can put something in the chat too if you want, and maybe Andrea could remove the chat. But do you have any suggestions of how to bring the two together? You know, some people are a little bit more reticent to, you know, work with EVS, or EVS doesn't want to work with infection prevention. Can you give them any tips of how to start that conversation?
So I think it's important that you got to get to know, you know, and yeah, we can be the first ones to initiate those calls, those relationships. One of the things that the team in infection prevention at our organization, of which Pam's a part of, and she's been instrumental in that, is being there as a support and not accusing one, you know, the environmental services is doing something incorrectly. You know, we typically team up and look at a solution together of what's going on. I mean, I'll be very transparent with you. Our bone marrow unit, up until this last 2 weeks, every time a patient discharged, we have some pretty strict cleaning guidelines up there, which does get us excellent outcomes. Well, one of the things that we do is after every patient discharges, we not only terminally clean the entire area. We take down the shower curtains, and that's another environment where we have the disposable cubicle curtains. We replace those after every single patient. We also replace the shower curtain after every single patient. Well, guess what? We don't have any right now, except the 20 that just came in from Target today. But so we had a collaborative call that I set up earlier today, and in between the nursing on the bone marrow unit, infection prevention, and myself, and what are our solutions going to be. So we talked about looking at seeing if we can clean them with our sporicidal disinfectant, and then every 30 days, and we'll decide what we think it's going to be the first of the month, we'll replace them then. We think we can buy enough stock from retail right now to be able to keep up to that commitment. And then once the supply chain comes back, we'll go back to our old process. But that's how we typically partner. Pam and I have been involved in conversations similar to not that exact same one, but we also have a great infection prevention team out in the outpatient settings that are more than happy to come and do the walkthroughs with myself and the vendors to make sure that we're maintaining the standards.
Yeah, communication. It can't be any better than that. And the frontline people are so important. If you make sure they're part of the solution, you ask them their questions, you engage with them, you can learn so much from them about what the problems are. So please, I encourage you guys not only to work with, your EVS directors or managers, but really work with your team, because they're the ones with the boots on the ground and they really know what the problems are, and they're going to tell you if it's going to work or not. So let's see. Somebody else was talking about your struggles with their IFUs and product compliance. That is a huge deal right now. We try to get everybody to, look up the IFUs on their iMeds and their glucometers, and there's just a lot, and it's a huge struggle. Anybody else out there having that kind of problem, trying to match the IFUs with their disinfectants? That they want to share any ideas?
While they're thinking, Pam, I just wanted to share one thing. If you don't have a relationship with your EVS folks, obviously, yes, you need to get one. But a great first step is to take them breakfast for EVS week.
Yeah.
It really, it's like, yes, we recognize it's EVS week. Yes, we want to say thank you for your role in reducing healthcare associated infections. Yes, you're critical. And, we all like to be honored during our, week of the year or whatever it is. So that's a great first step and a great way to break the ice with a very positive approach.
Agree. Thanks, Beth.
I love that. Yeah, I will tell you, during the pandemic, infection prevention brought each one of our hospitals brought us cookies and helped us, encourage the staff, because it was a struggle for them. If you think it's a struggle for you, or if you think it's a struggle for a nurse, it's even more for the struggle when they don't have that knowledge base, and they live in fear of what they're going to walk out of work with and take home to their families. And it's through you all's support and education, coming to our meetings. I mean, I can stand up there and do a presentation on hand hygiene. It's never going to be as good as if Beth or Pam do it for me, because it's an expert coming from another department, and they're the expert in this particular part of the business, and it makes a huge difference. So really connect with your environmental services leadership and see, can we help you at your next, departmental meeting with an educational component? It just makes a huge difference. And we know we could not do it. And we're the infection prevention army going out there each day, right? Trying to fight these pathogens, but we could not do it without the infection prevention team at our organization.
One of the things I found that really works is, we like to do PowerPoint presentations. I go around and ask the EVS people if I can take a picture of them mopping the floor or cleaning the bed or something. They love to have their picture taken. Ask them first, obviously, but they love it. So, you know, oh, I just went into our team meeting and Susie, you were on the screen, and they just kind of like that because it's an engaging thing. So I lots of times try to do that. And then if we're talking about like wearing gloves, I'll give everybody a pair of gloves and I'll say, let's put this on and let's practice taking them off, and very engaging with them, and they love it and they pay attention really well.
Yeah, you all really make a difference in environmental services team members' lives, and we can't do it without you. And, you know, Pam really brings up a good point, how engaging with them. I was at one of our sites yesterday, and we went into a room that had just been cleaned, and there's very few of those right now. As we all know, census is through the roof, but all of the hospitals. And we went into this room and we found a couple things that weren't really the responsibility of the environmental services worker, but they needed to be reported to engineering to be fixed. So I went back to the environmental services worker's cart and I said, you know, just reinforcing, just saying, you know, make sure you let somebody know in leadership so we can get this input into the work order system. And then she said, well, she said, did you see the stuff on the ceiling? I said, no. So she said, let me come show you. She takes me back into the room, and I mean, here I am, honest. I didn't see it, but it looks like some kind of food substance was on the ceiling in the room. And there was a couple of us on this walkthrough, and it took all three of us about 15 minutes to get it off the ceiling. But it's the importance of that communication. The fact that we went up to her, you know, I engaged with her, and then she gave me information that was so important to act upon, because there's nothing worse than a patient laying in their bed, staring at the ceiling, and they see food particles up on the ceiling of their room. So yeah, engaging with them, it makes their day.
Hi, this is Tanu. I'm an infection preventionist at Emory Johns Creek, and thank you so much for that wonderful presentation. We love our EVS team. Just wanted to.
Still there? Is David still there?
David Hatcher or David Simmons. Yes, he is.
David Simmons.
Yes, he is. I just joined 2 weeks ago, and yes, I've already had some great interaction with him. I'll tell him you said hello.
His mother worked for me at St. Joseph's, and so did
okay.
He. Yeah.
Okay, lovely. Yeah, you know, just to add to some of the things that made lives of EVS personnel a little easier was, and I'm sure a lot of us out there have it, you know, having a distinct list of the equipment and things that EVS is responsible for and what nursing is responsible for, because a lot of times it would be like this. So that was one thing. And the other thing that one of my colleagues at St. Joseph's had done in terms of engaging and educating them is set up a scavenger hunt, like an escape room, to teach them the concepts, and it was a huge success, the escape room. And actually we got the idea from one of the APIC presenters at the national conference. So if anybody wants to do that, it's a lot of fun.
I love that. That is so cool.
Yeah. And the last thing that I wanted to mention was that it's becoming really challenging to find the universal disinfectant that kills organisms, like especially the emerging ones like Candida auris, and matches the IFUs. So you know, that is a challenge where infection prevention and materials management and EVS needs to work very closely together to determine what is the best disinfectant and, you know, detergent to use. So
well, and you know, the other thing is how's the disinfectant being applied? Is it getting the correct dwell time? You know, all of that information. I mean, I'm gonna be transparent. Yesterday when I did this walkthrough at this other site, none of the microfiber mops were in the buckets. And so I asked the staff, I said, well, where's your microfiber mops? And they went in their cart and they brought out their, you know, microfiber mops. But our program says that we're going to have it soaking in neutral cleaner. This is for patient rooms. This is not sterile environments.
Right.
And you know, we had fallen off our program. Okay. And, you know, I got with the leader afterwards and said, you know, we need to get back to what we were doing. But that's why it's so important with these partnerships and these walkthroughs, you know, to, you know, everybody collaborate together to make it better for the patients.
Right. I have one question. Do you use any qualitative, program like DASO or ATP to assess the cleaning efficiency, efficacy?
We do use ATP, and we do all of our surgical suites once a month. And then we do 5% of our discharge rooms. In addition to, we ATP every C. diff discharge room. And if we ATP a C after it's been cleaned, and if it fails, then we have to go back and re-clean the room completely over. And then we present that information at the monthly infection prevention meeting. So hopefully, you know, David at your place and whoever your EVS manager does have a seat at the table for the infection prevention meeting. That's really important. But, you know, sharing that data, and you don't have to use ATP. Like you said, DASO's available too. My piece on DASO is that it requires 2 visits to the room. Okay. And if we're this short of labor, and the other thing is that what is the highest cost element of your program, and it's labor. So on the surface, DASO looks like it's much cheaper, but when you start investigating, I know the cost of the swabs for ATP is a little higher. And of course, you've got to buy the luminometers, but we have decided as an organization, ATP is the way to go. It doesn't mean everybody does. But I believe CDC also says you can do a physical inspection. I mean, obviously, you're not going to get the bioload off of the surface or, you know, the DASO gel, but, you know, just having a program for inspection and being able to measure and present those results is really, really important. We also gather the information. This is part of what we get from Aramark, but we have a system that gathers our I-rounds and our inspections. So we know how many inspections our managers are doing every single day. We have that data pushed out. And then we also have a patient satisfaction component to that, where they are required to do so many patient interviews as well.
Yeah, the HCAP scores. And yeah, we at Johns Creek, we do have the ATP. I just was curious to see what others are using and if any. So thank you for that information. I appreciate it.
Say hi to David for me.
I will. Thank you so much, Ms. Fiona.
Thank you.
So Fiona, there's a question in the chat. I'm going to read it to you. In the outpatient world, when EVS is contracted by the building management, it's helpful for the specific site supervisor to ask for a copy of the specific items the EVS is responsible for and the frequency of their cleaning. Because just because you contract with, you know, Mr. Smith's, that doesn't mean that you have the same, you know, expectations. So you want to just share a little bit about that?
So, you know, the point's well taken, but, you know, the challenge is how much oversight you have when you're not paying that person's invoice. And so it really, again, requires collaborative partnership to kind of motivate that person up. As you know, Pam, you and Beth have really helped me out in leveraging. At one point, we wanted to make sure that at least all of our outpatient settings were being cleaned with an EPA registered disinfectant. So the way we leveraged that out to the places where we didn't contract for the cleaning, we sent it out to the property managers, and we quoted the CDC requirement. And we said, please, can you confirm that our suites within your building are meeting the CDC requirements of being cleaned with the EPA registered disinfectant? And Pam and Beth helped me to do that. And we did it across the health system. Because it's too easy for somebody to come along and clean with Pine Sol or, you know, some of those other products. And don't get me wrong, we are not perfect. I don't want to tell anybody we're perfect. We had a situation somewhere in the health system early on COVID, where if you remember, once there was somebody who been taken ill with COVID, they wanted a terminal clean of that particular area. So we had gone, not me or anybody from the hospital, contract cleaning company in one of our buildings had gone to do perform the terminal clean. And luckily we had a leader in that area, had some critical thinking. And what she observed was the microfiber cloth that everything was being wiped down with looked pretty old and tatty, and she didn't feel like their area had been cleaned properly. So the information came back to me, and then I got to collaborate with the property management team, and they said, well, would you be willing to come in and do an in-service with our staff just to make sure that we're meeting the guidelines? And I said, absolutely. So 6:30 that night, I went to do an in-service. And it was so interesting to do that in-service, because what I learned from the staff that were working for that contract cleaning company, and their leaders were there too, we invited everybody along, they didn't have a laundry process for their microfibers. So their microfibers, as gross as this is, they would use them. At the end of the night, they rinsed them in the janitorial sink. They hung them up to dry. And then after 30 days, they threw them out and they got a new one.
Wow.
And, you know, this is in a health system of our caliber. Of course, it doesn't exist anymore. It was changed immediately, but there was no laundry process for them. And, you know, that could be easily fixed with disposable wipes, putting a laundry contract in place. There's just numerous ways. But I was so happy I went and taught that in service, because that's how I gathered the information. So sometimes it's not just sitting on the surface, reaching out to you saying, you know, and this particular contractor cleans for all the health systems across Georgia. They're not just a Northside contractor. So, you know, it was definitely worth doing that training.
We have another question in the chat. Our facility has been doing a lot of construction lately. Do you feel like it's easier to contract out terminal cleans or use in-house EVS?
So we kind of have two pieces there. They will do the construction clean on our projects, and then environmental services will go and do the final terminal clean. The reason why we don't contract that out is we haven't found a contractor that can perform the terminal clean at the level we need it to be at. If there was one, we would definitely consider it. We're not against it, but we haven't, you know, we still have to go behind the contractor that says they do the terminal clean. So what we've decided as an organization, we'll do the construction clean with a contractor, and then environmental services will come in and do the terminal clean after that.
Good, thanks. Anybody else have any other questions? I don't see anything else in the chat. Unmute yourself if you do. Fiona's a wealth of information.
Thank you, Pam.
Andrea, I think we're going to turn it back to you.
Hey, this is Mary. So Andrea actually had to hop off a little bit earlier. So I just think closing things out, right? We really appreciated the speaker today. I think we all learned a lot. And just a reminder that our next meeting is going to be at the zoo. So we really hope to see you there. And you can still make sure that you register through that flyer and make your payment that way. Are there any other last minute thoughts or feedback for the team before we end the call?
So Mary, my husband has been on the board of directors at the zoo for just about 20 years. City of Atlanta actually owns the parking, not the zoo. So for everybody's information, you will have to pay for parking at the zoo. So I don't know if you want to carpool or whatever, but I just wanted to bring that up.
Thank you. That is really, really helpful information. And I honestly was not aware. So great to know. Thank you. Anything else for the good of the group that anyone has before we end the call? All right. Well, thank you, everybody. Thanks so much again, Fiona. We really enjoyed having you today, and I hope everybody has a good rest of your day.
Happy Thanksgiving, everybody.
Bye.